Hey, Mehmet, how are you?
Very good, very good. Thank you for having me and appreciate the invite.
It's great to have you on the podcast. I'm looking forward to diving into hips and groin pain and busting some myths and misconceptions.
Yeah, thank you, mate. It's nice to kindly make my debut on the podcast and hopefully people enjoy it. We'll try and jam pack in as much as possible and hopefully people find it useful.
Absolutely. So, first off, where are you based?
Yeah, so I live in Devon now, so it's like southwest coast of England. I have done for the last few years. Grew up, though, my whole life. I was kind of raised and lived and worked my whole life in London. The last 5 years have been a bit of a change. So I've gone from a city life to raising kids and living with kids and wife down in the south coast in a rural area now, which is quite nice. I've been a physio for about 15 years now and specialised in hip, groin type physio speciality, probably for about 10 of those. So I knew what I wanted to do pretty early on. I had a really, really distinct insight and it stemmed from my own experiences. I had FAI, which was at the point of when I was qualifying, and I didn't know anything about that. I had surgery, didn't work out too well, and then basically at that point, I was really keen to learn, just become a physio. I was thinking, I want to know what's going on with my hip, and on the other hand, I was wanting to use all the opportunity I had for like in-service training, CPD development, to just correlate with what I was trying to understand about my hip. And that took a while. And then obviously what happens is as the years go on, and then I was doing like a post-grad masters, again, anytime I had to do any kind of research or review, whatever, it was all hip related. Years went on and I basically spent all my time trying to learn about hips pretty much from the day dot. Don't get me wrong, at the beginning, you don't really know anything, do you? I was just winging it for the first 2 years, but pretty much that stemmed an interest. And then after a few years, I realized actually I know what I want and I know what I have a passion for when it was hips pretty much from an early period of time. My hip's fine now, so it's all sorted out. And that's what's led me to doing pretty much what I do now, really, which I'm very grateful for.
It's funny how those experiences shape you, and it can be sometimes injuries you experience yourself or different patients you see that sort of shape the direction that you go in. So it sounds like it was a bit of a journey of self-discovery at the same time as you were looking into how to treat hips and getting a real interest in it at the same time.
Yeah, definitely. I'm pretty happy with how things transpire and how I've got to this point now. I wouldn't say necessarily everyone who's a hip specialist or shoulder specialist or knee specialist has to go and have an ACL reconstruction or a shoulder replacement just to get some sort of like insight or empathy, but it's useful. It certainly helps shape my perception and awareness and more importantly, the passion. And I love it now. Have such a huge passion for hips and share some like decent information. I think that's what I'm most passionate about. It's quite a complicated area. I just want to share as much good information because unfortunately, because it is quite a difficult area, sometimes misinformation could be rife, especially on online outlets and social media and stuff like that.
Stuff. There seems to be lots of myths and misconceptions, and glutes seems to be one of the big ones where there's a lot of myths around glutes. Tell us a little bit about some of the myths that occur around glutes, particularly to start with.
The amount of traction that some of these myths get is fascinating. It was always like the more obscure, random, and simple like these myths are, the more people hook onto them. But I get it because ultimately, who's the audience? The audience is someone who's in hip pain. And realistically, someone who's in hip pain, they just want a quick fix because ultimately you're in pain. You just want to resolve it. Something that was so common was this glute amnesia situation that come up. The actual term amnesia and glute together doesn't make sense. It's like saying like happy teapot. Those things don't come hand in hand. Glutes and weak glutes have inherently been blamed for everything that's wrong with the world. But for people who have hip pain, it's such a oversimplified approach to take. One person's one muscular weakness and strength deficit, one is not going to be able to correlate with their pain, but it certainly isn't going to be the singular blame for someone's experience. But trying to explain what I've just said isn't as sexy as a term like gluteal amnesia that seems really straightforward and that you could fix by doing this exercise that you'll find on this person's Instagram page or this person's YouTube channel. So unfortunately, those are one of the things that I probably come across. And I get like how sometimes it's explained to try and simplify what's going on, but also you don't want to be giving patients information that's flawed just with the hope of that's easier for them to understand, because that's not the case. You've got to make sure that we're giving them right information. But equally, you don't want to bombard them with science either, but it doesn't mean that you lie to them and just say things like your glutes are switched off, because they aren't. If you're walking about and you're sitting and you're standing up and you're putting your shoes on and you're going outside or upstairs, they are on. It's impossible for it to just like all these other muscles are working, but one of them's just asleep or switched off. And that's all bugbear of mine.
Can glutes get switched off or get amnesia?
No, I think no. I think glutes, any muscle could certainly become deficit in their strength or kind of functionality. But ultimately, if you have motor loss of a muscle, which is the fact that the muscle is not firing because there is some sort of like input that is inhibiting its function, that's a quite unique and significant scenario. So in regards to the common theme that we see with these patients, and often when people are being told this, that's not what's happening. Actually, to be honest, I would hazard a guess the majority of the time, the glute strength probably hasn't even been tested to then be able to say it's switched off. So at that point, I'd say, no. For me, gluteal amnesia is a term that's been made up that doesn't have any kind of like decent clinical validity or applicability. I'm quite lucky to be at the cold face of like hip physio. I probably should also point out that my opinions, I try to base them on evidence-based background and research and understanding. I appreciate not everyone's going to agree with it. I'll talk to someone like, look, I'll tell you, I'll be open, I'll be transparent, I'll be pragmatic. I'll tell you what I know as it is, but also understand that I don't know everything. None of us know everything. There's going to be like limitations and levels of ambiguity to all of this stuff. But if I feel a little bit more certain on something, I'll be a little bit more assertive with those thoughts. And this is probably one of those where I'm saying switched off glutes or gluteal amnesia. I think it's something we probably need to just steer away from a little bit.
Have you had a patient come in and say to you that they've got their glutes switched off, or their glutes have forgotten how to fire, or they've got gluteal amnesia?
What's the first thing someone does? They go on Google, they'll type in, what is my hip pain? How do I get rid of hip pain? Why does my side of my hip hurt? Whatever. And they might come across that. And then they come to see a physio, and that physio is sitting in front of them thinking, I've just listened to Mehmet talk. I've just gone on his course, blah, blah, blah. I know that this thing isn't even like really like valid. But if a patient comes in and they say to me, like in my clinic, and they say, oh, Mehmet, you know what? I've got a problem here. My glutes are switched off. Or I went and saw someone and they told me that I've got gluteal amnesia and I've still got this hip pain. And I know that from talking to them, that hip pain is probably going to be a little bit more complicated. It might be hip joint pathology, gluteal tendinopathy, deep gluteal pain, whatever. What you don't do at that point is then just absolutely slate the other clinician that's told them, slate the other physio, or disregard what that patient is telling you. I think that's a really important thing for any clinician to understand, is just you've got to show a level of respect and professionalism across the board, even if they're telling me stuff and I think, geez, that's honestly bonkers. Like whatever you've been told makes no sense. But you don't want to confuse the patient. You don't want to make them leave thinking, okay, I've had now two quite conflicting bits of information. You have to put yourself in their shoes and think, how can they leave understanding better what it is that I need to do? A lot of that comes down to saying, I understand their thought process. I understand what you've been told. There might be some glute involvement. What we could do is probably try and refute that through your assessment, or even if there's involvement, we can integrate that into your plan. But also, if you've been doing stuff and it's not got any better up until now, there might be something that's been missed. So we'll go through that with your assessment and see if that's relevant or not, and just try to educate the patient, but like bit by bit.
And you want to gradually challenge some of these beliefs, particularly if they're a little bit maybe wild beliefs, but you're also not looking to straight away just hit them with, that's absolutely not the right way to think about this. We figured out glutes aren't getting switched off or getting amnesia. When and how do you test glute strength?
I think any hip strength testing is quite vital, but I think it will be relative to the individual in front of you. I think one of the pitfalls that often clinicians, they associate contractile muscle testing with strength testing. Like those things are really quite different. If you're pushing someone's hip against resistance or abduction or hip extension with your hand and you're just resisting a resistance, that's not really strength testing. You're just like testing the fact that that muscle can do something, like it's active, that it can resist resistance from a contractile perspective. That doesn't give you any data. Like just ranking something 4 out of 5 or 5 out of 5, that doesn't tell me anything. It doesn't tell me if it is weak, how weak it is. It doesn't tell me what plane of movement is a problem, doesn't tell me really from a rehab perspective where to focus, right? So if you're testing someone's glute strength and you're using handheld dynamometry, if you've got them prone, if you've got them upright, if you've got them supine, whatever kind of like hip type strength test that you're doing to elicit some sort of response, if you do like maximal voluntary isometric contractions and you're trying to get some data, then I'll have that discussion. Like if it is weak, it's weak. How weak is it in comparison from left to right? What's the asymmetry? Is there an asymmetry? Because the thing is as well, Dave, like that's going to help guide your rehab. Like this is a thing that I tell all clinicians whenever I'm teaching is you got to answer me why. Like you have to answer my why question. Let me ask you this. For someone who's got like weak glutes, what would you comment it as an exercise given for someone who has for glutes that we all know?
Hip thrusts are a pretty common one.
They use loads. And when I'm talking to physios, I'm like, let's talk about rehab. And they're giving a hip thrust. Why are you giving that to that patient? Because you're giving it to that patient for their glutes. Or if you're looking at like EMG recording data studies and you're saying, I know that step ups are great for glute max. I know that side planks are great for glute med or whatever. Why are you giving it to them? Bicep curls are great for bicep, but like, why does that bicep need to be worked? If you're telling me though that you're looking at the data and there is a deficiency or a real notable deficiency, and you feel like that may be playing a role in that symptom, that patient's presentation, then great. Then we can funnel that from their assessment into their treatment. And then you're selecting exercises based around that, but also loads of things will contribute to that weakness. One exercise that focuses on one muscle isn't going to be the answer. All these muscles do slightly different things. They all work. You have synergists as well. They work in different planes of movements and angles. That's where rehab for me gets quite exciting. And often patients recover better if your exercise prescription is really clinically reasoned. So in a roundabout answer to your question, manual testing is useful to see if there is an inhibition or an inability to resist manual resistance or gravity or whatever. But actually getting some tangible data is what will then help you. Now, you don't necessarily need to do that for everyone, because if you've got an athletic individual who has hip pain, and on the other hand, you have less active patient who maybe just has some, let's say, gluteal tendinopathy, 55-year-old patient, gluteal tendinopathy, who isn't really that active, but has a high level of pain. Like that kind of, you start to create the question, is it worthwhile your time trying to do a full kind of hip screen for that? But then again, and it's just almost like a paradox. I'm like contradicting myself, but I'm purposely just trying to demonstrate the level of the situations where it might not be relevant for everyone. So I think, but again, you'd be able to answer why though. If I said to you why, you'd be able to have that argument.
Handheld dynamometry sounds like it's a pretty common, you use that a fair bit within your clinical practice. Any other sort of tests that you tend to do when it comes to testing gluteal function, strength, that sort of thing?
We have a lot of normative data for calves, for example, single leg calf raises to failure relative to age and gender. We don't really have that for the hip, to be honest. There's some more data coming out, but it's very specific. It's almost asymptomatic, high-level female footballers. That's the most recent one. But we don't have it as generalized for the other stuff. But we still get information. For example, if we're looking at glutes in isolation, well, you could get them to do pelvic thrust, but some people would struggle with that if they had hip pain anyway, or they might be able to do too many for you to get a good insight. So you could say, if you've got a chair, you could do single leg high box step ups to failure, see how many of those that they can do, if they can and if they can't. And also just trying to understand that you're just trying to understand how many that they can do, but also the quality of their movement. And then it's using that same principle for other things. Adductors, you could do a straight long lever Copenhagen single hold to failure, symmetric hold. You could do the same with a lateral plank, side plank on one leg, maximal hold, endurance test. Same with the hamstrings, single leg hamstring bridge on the chair, 90 degrees at the hip, 90 degrees at your knee to failure. But there's loads of opportunities for you to get, it might not be as accurate, but it's still, you're getting some information. I love a single leg sit to stand from a chair. I think loads of people can't do it. You get people with hip pain that are still training in the gym. And I'm like, great, you're still training, you're still doing your compound lifts or whatever, but you can't do a single leg sit to stand from a chair, but you can do it on the other leg for 20. What's going on in the gym when you're lifting and doing heavy deadlifts still now if you can't do one leg raise from a chair? So I think that starts to paint a bit of a picture
You mentioned there's some really nice ways to test it when you don't have a handheld dyno. You can use some of those more functional sort of tests and check what the time to failure is, or how many reps they can do when you're comparing side to side. If you've identified some deficits, tell us a little bit about some of your favorite exercises that you tend to use. If you identify that they've got a deficit, where do you tend to go? How do you tend to structure someone's rehab?
Rehab is easy to get right if you just have the right principles for what you're trying to do. But those principles will start from not necessarily the best or the sexiest exercises. Some of my most effective exercises are like the most boring things in the world. But there's an important element to that we need to make it not boring for the patient. So I think rehab is really important from the perspective of making sure that the patients are adherent to it, right? So it doesn't matter how much information that you know, how much knowledge, how much information you've gathered from in-service trainings or CPD. If your patient doesn't do the rehab, nothing happens. The hip's not going to get better on its own. To get that output, you need to dose it perfect. You need to make sure that it doesn't irritate the pain too much. If it does, you've educated the patient on how to manage it themselves, how to regress, how to, within that week, just tailor it a little bit. You need to make it fun. I can't be asked to do rehab if it's boring. If you just have someone that has a sheet of 10 exercises that they could have got off the internet, it's boring. Like, no one's going to do that for 4 weeks if you're asking them to do it. So the length of the rehab set or session is really key here. So sometimes I would probably pick 4 is my sweet spot, 4 exercises. Even that can be a bit boring. I say, look, this is what I need from you. 20 to 30 minutes, 3 times a week. That's what I need from you to start with. That's almost like an hour and a half of your life a week for the next few weeks for us to start to see some sort of change. And they say, okay, fine, I can do that. My job then at that point is in those 20 to 30 minutes to make it effective, clinically reasoned, and fun. But also the fun comes with a lot of my patients want to exercise. They want to feel like that endorphin hit. They want to feel like they're training. So I find circuits work quite well. So I can normally say, look, you've got 4 exercises. You do 1, 2, 3, 4, have a little rest, time your rest, 2 minutes, 3 minutes, do it again. And we do that 2 or 3, 4 times. And I want you done in half an hour max. If it's taking any longer, let me know, drop it down, whatever. And what that does is it facilitates like positive reaffirmation in the sense that they get to the end of week 1, week 2, week 3, and they've done it. They've done Monday, Tuesday, Wednesday. That's so much more empowering for a patient who has hip pain than the complete antithesis of that, which is I've got an hour of exercises that I've been told to do every week. I've got to end of week 1. I've done 50% of it. I've got to week 2. I've done 50% of it. I've got to week 3. Shit, I've missed the other 2 weeks. It's probably not going to get any better. I'm already struggling. What's the point? I'll leave it. And then they move on to the next thing. And I think that comes down to us. That's our responsibility to just understand that person and that individual so that we keep them adherent to it. Now, the other thing as well, you said, what's your favorite exercises? Things that are boring and simple, sometimes the most effective, but we also can't do them forever. The step ups, the side step ups, the single leg box squats, the single leg RDLs, they're all great. Many patients benefit from challenging lower limb strengthening exercises. And I find that for my cohort of patients I work with, who are often a lot more active, benefit better than the lower level bed-based like Pilates, clamshells, pelvic bridges and stuff like that. For some, that's great. Don't get me wrong. There are some patients that are too irritable, too painful. That for them is great. But also we need to elicit a response. And to elicit a response, you need to do stuff that is going to be effective. So although some of the boring stuff at the beginning works quite well, you also need to change it and adapt it. And that's when the assessment findings come into play. And the selection of exercise for me also comes down to thinking, these are the things I need to work on. These are the exercises, but also understanding that these exercises we can tweak and change with angles, weight, dynamic movements to then take it to the next level so it doesn't get stagnant. And that's quite important.
Say we're looking at a gluteal tendinopathy. What's the sort of exercise that you tend to avoid or that you tend to include with those sort of patients?
Yeah, glute tendinopathy is surprisingly quite a challenging condition to manage. On paper, you think it's just a tendon. We're pretty good at tendons, healthcare practitioners. We know a lot more about it. We know how to manage it. But GTPS, a great traumatic pain syndrome, which is the umbrella term. 8 to 9 times out of 10, you're dealing with a glute tendinopathy is the main culprit, to be honest. It's a challenging cohort in the sense that there are not the most simple directed tendon risk factors at play. We've got other factors intrinsic as well. So things like people have got like systemic, inflammatory, hormonal changes that might have put them at risk or playing a role in their symptoms in particular. But also a patient cohort that not all the time, but sometimes maybe are less active, maybe are a bit more sedentary and don't do exercises in comparison to the FAIs and the hip dysplasias of the world. It does mean that where you have someone who has a high level of pain, high level of irritability, and a duration of symptoms that have probably persisted for months and months, you do have to tailor it, because actually the way that we manage GTPS in particular is twofold. You could give someone in this patient group the absolute creme de la creme exercise rehab plan that you think should work within 6 to 8 weeks. But the important thing here is if you're not also educating the patients on some of the things that will provoke it and behaviors that might not allow them to recover as well, I don't think it works as well. Like when you look at the key paper, the LEAP trial that was published years ago, that was like a great demonstration of how well Physio can work to manage people with GTPS. There's 3 groups. I was wait and see, steroid and the Physio group. It isn't just physio exercises for 8 weeks. It was a program on load management, education, and exercise. And that education, the reason it works so well is because consistently you're educating. They did almost 2 sessions a week for 2 months almost. You think if you're telling a patient and educating them that much, they'll remember it. Remember I said before, like normally in that first session, they forget most of it. But if you're telling them again in 3 days and then again in 4 days and again in 3 days, they probably are going to retain it. And I think that education piece is really important. So although we've got exercises that we would use that, yeah, you probably would do, they probably would fall into the category that I said before. Lower level, maybe bed-based, a lot just general activity, getting someone walking a bit more, just trying to functionally get them moving. But also on the other hand, we've got to educate them on some of the stuff that might provoke it, which unfortunately is the first thing that they would do, because they would go on Google and they would, like I said, search for something and they end up coming in telling you that they're doing foam roller, tennis ball release, trying to stretch their IT band, or doing like absolute savage glute stretches because that's what they've seen or someone's told them to do. And then we're thinking, well, actually, like that glute stretch that you're doing is also the same as a diagnostic test that I've just done to elicit your pain. It doesn't really make sense because I'm trying to get your hip to hurt, but you're doing it as a treatment. It's not their fault. It's just what they've picked up. So you're trying to unpick that. And those things, from a management perspective, have to come hand in hand. You can't do one without the other. And that's why it's quite a difficult patient group, because we're trying to progressively load a tendon at the same time with a patient who probably doesn't want to, not all the time and not all the time, but like majority of the time. And that's a challenge, but I find it a good challenge. I enjoy it.
That education piece plays such a large part. I've had patients come and say, oh, yeah, you're asking them, do you do any stretches? No. And then you find out a little bit down the track when they say, oh, I normally sit at night and just in front of the tally and I'll just sit with my legs crossed like this and pull my knee across. And you're like, okay, these are some of the things that we need to explore. And you start to find out some of the things that are actually contributing. Or like you say, they've done some research and they're just, they love to stretch, or they've picked up some exercise. Someone said, you need to do this piriformis stretch or whatever it might be that they then go and aggravate their lateral hip tendinopathy with.
Yeah, and that's that. And the thing is with this, and I think it's worthwhile, just it's not a debate. I try not to get into debates online and stuff like that, but I see it happening. But one of the only debates probably I've had is this concern about educating patients on things maybe to avoid. Now, I get that everyone in that should be able to do everything. Yeah. Compressive load is normal. Yeah, you should be able to tolerate it. I get it. But also, if you're with a patient who can't tolerate a compressive load, like with the stretches that you mentioned there, it doesn't make sense to just hammer and knock on the door of pain all the time, because it doesn't help. It will increase their sensitivity. It will reduce their mood. It will reduce their compliance. Loads of knock-on effects to that stuff. But it's the understanding of the patient that you're not going to avoid it forever. I'm not telling you not to stretch. It's just now for a few weeks. Just let's see if it makes a difference. The interesting thing is what you said before. Some patients do stuff that you think shouldn't help, and it does. And I've had patients come in and they say, that's the only thing that gives me some pain relief. And I'm thinking that's the only thing I probably don't want you to be doing. At that point, I don't turn around and say to them, well, you know what, look, actually, when you're doing that, the excess compressive load at your tendon and surgeon is probably going to exacerbate. They don't care about that. They're just like, it feels nice. So I'm like, okay, continue to do it, but do my stuff as well. And if you're not getting any better, because ultimately you're here with me now and it's not better. So whatever you've done hasn't been enough. But if you love that exercise, do it, but do my stuff as well. And if you're not getting any better by, and then I'll set a date, I'll say give it 5-6 weeks. If you're not even a little bit better, and I'll refer to it as like a net gain of rehab, because this isn't going to resolve in 6 weeks. I'll just say if you have some net gain in rehab by 6 weeks, then we'll have to probably drop that one thing that I think might inhibit our progress. And if you're not and you're progressing, then we'll keep it in. And I think that's really important to consider, but it comes back down to the thing that I said before about people are sometimes doing stuff that you think, I wouldn't have advised that, but they love it and they're saying it helps. So who am I to tell them to stop?
We've talked a little bit about glutes, and you've mentioned there stretching and those sort of things. Now, hip mobility exercises on social media, there's lots of people demonstrating all sorts of different hip mobility exercises as such. Tell us your thoughts on hip mobility and whether patients should be doing different hip mobility stretches and some of the misconceptions around that.
Hip mobility for the general population who just have a bit of a stiff hip but aren't in debilitating pain is fine. If it helps you doing it, then great. There's no problem at all. For some, they love it. For someone who's got hip pain and they've got hip joint pain that is specific to a hip joint pathology that is presenting with a stiff hip, which is often when this is used, because no one's going to go and look for improving their hip mobility unless they think my hip mobility is diminished. And often that is a cohort of patients that fall into like hip impingement or femoroacetabular impingement syndrome, FAI syndrome. Because with FAI syndrome, often those patients are the one that do have a stiffness of the hip, either into deeper flexion or internal rotation at 90 degrees, or even into external rotation as well. So they have that stiffness. Now, is that stiffness because someone has a morphology of the hip of FAI that's restricted their range of movement? Does that individual have a version or an acetabular version of a hip profile? So you've got obviously ball and socket, and then there are varying different versions to how that socket may sit, and also the profile of that hip in regards to how much it rotates. So if you have like a retroverted profile, your hip will rotate less into internal rotation anyway. And if you had an antiverted profile, it'd be vice versa. But then equally, if you have someone who has a CAM-related FAI syndrome, they'd have loss of internal rotation too. So you're thinking, what are you trying to gain there? You're trying to push against a structural restriction, like a bony restriction, that actually will probably precipitate more problems later down the line. On the general kind of what I've just said there, like when you're searching, people are searching for stuff on hip mobility or whatever, like none of this stuff would get mentioned. It's not sexy. And someone who isn't necessarily aware of that when they're giving that also to the patient might not be aware that that restriction might not just be a soft tissue stiffness that they've got. Actually, what you're doing there is probably just jarring the hip. With that, unfortunately, what it could lead to is things like joint effusion, or even in some extreme cases like iatrogenic instability of the capsule, because essentially you're stretching it past its capacity to tolerate that range of movement. And I think that's where my limitation to it is. I think I'm not against it, but I rarely use it. And where I would use it is if I have an athlete who requires these real extreme ranges of movement for the sporting performance that they're trying to do, and they're possibly recovering from surgery, then I would at that point utilize it. Or if I'm utilizing it conservatively, trying to get as best, because it is a challenge clinically, but getting as best an idea into what their profile is and working within those means, rather than trying to find the endpoint restriction and then pushing past it.
So if a patient comes in and you're testing them and they have got restricted, say, internal rotation at 90 degrees, and what's your thoughts here on trying to improve that? Is that something that you'll work on? If it's just the person's come in because they might have some hip pain or some hip stiffness and probably a combination or something like that, or maybe they've come in with low back pain and they've also said, oh, my hips are pretty stiff. Tell us a little bit about how you might approach that range of movements and things that you might avoid and things that you might include.
Yeah, I definitely wouldn't focus too much on the avoidance perspective, but it's going to be really hard to refute that there isn't these morphological causes that are restricting the range of movement. And that's the same for me as well. Like there's a degree of, I'm not really too sure why that's restricted. And I think that's not the only reason why it's not my top priority, but also there's many situations where if it was a hip condition, like for example, FAI, like I mentioned, the patients who do well from it that you manage conservatively have to have an understanding that we have to work within the means of what the hip allows us to do, condition it, strengthen it throughout whatever planes and angles of movement that you have access to, but also just be mindful that it might still be a bit stiff afterwards, but you might have no pain. You might still be able to play sport. You might have no pain. You might have full function, but you might just have less internal rotation still on that side. That might just be normal for you. And I think they need to appreciate that when trying to manage it. That doesn't mean you avoid moving into those angles and positions actively, but you probably would avoid someone sitting on the edge of a bed, holding their thigh and just doing loads of internal rotations repeatedly, because it doesn't increase it. You might increase it transiently, like for a few hours, but I suspect that's probably not actually like the morphology of the hip that you're addressing. So from my perspective, it's not my priority, which is surprising for people because they think someone who specializes in hips should be obsessed with like mobility and range. And majority of the time I'm not. I'm like, I just want to get people physically more robust, and actually making someone emotionally and psychologically resilient is on par with getting them physically robust for me. Like those two things come hand in hand. Everything that I do with patients from a physio perspective when it comes to exercise and rehab, I'm doing not just to make them physically stronger, but I want it to have a knock-on effect. I'm trying to make them like psychologically more like resilient to like the tasks that they want to do. And that kind of comes with obviously reduction in pain as well.
Hip mobility exercises as such, they're not tend to be something that you'll include too much in someone's program. For instance, you mentioned they're not just sitting on the edge of the bed doing internal rotation on their leg to try and improve that. Say someone has maybe a bit of hip joint irritation or their hip joint's involved in their pain. Have you found anything that does help to improve it? Obviously, we can't change morphology, but is there anything strengthening or manual therapy, any of that sort of stuff that you found actually can help to improve someone's comfort with their and potentially their range of movement?
Yeah, to be honest, like that's a kind of a very common approach. We know when we've got someone, young adult population, FAI, hip dysplasia, who do have, although albeit from two very different structural drivers to their symptoms, do have a structural driver to them. Ultimately, if you've got one that's got instability from lack of coverage and one that's probably got either too much coverage from a pincer or this kind of cam morphology, we have a joint condition. A common question that a patient might ask you is, how are you going to get my pain better if the cam is still there? How are you going to get my pain better if the pincer is still there? Because I'm educating them on morphology, and then they're asking me, like, how the hell are you going to make that better for exercise? Same with hip dysplasia. Educating them, explaining it to them as a possibility, not a definitiveness, because it is hard clinically to diagnose these things. But there might be an instability or a lack of coverage. And then they say, how are you going to manage that? Because if there's a shallow socket, then how's exercise going to address that? And the argument is like, none of this stuff has just happened. Your cam has been there probably for 2 decades. Your pincer has been there since the same time when you've developed in adolescence. Same with the hip dysplasia, like either happens in infancy or secondary ossification during adolescent development. If you're presenting with symptoms when you're 25, 30, like they've been there a while. Like you're just getting symptoms in the last 6 months to 10, 12 months, whatever. But those things have been there, which means that for a significant amount of time, your hip has tolerated it, managed it, and been absolutely fine. What we need to do is create a program that allows your hip to do that again. All right. And create a program that allows it to have the strength and the conditioning and the stability and whatever it might be to allow you to get back to where you were before. And I think that's really important because often patients, they might come to you with an X-ray or an MRI scan and it might say labral tear, it might say cam, it might say pincer, whatever. And then they don't know that sometimes it's just normal. People just have those things. It doesn't equate to pain. So then your program has a little bit more like back into it, because then you're like, look, what we're going to try and do now is focus on trying to build your strength tolerance, whatever it is, function tolerance, whatever it is that we're trying to address, but also be mindful that there are circumstances where it's fine don't worry, you're not going to need surgery. And I think that's what patients really get concerned about, is that when they hear structure and morphology, that the only way to fix that is to go in and shave it and repair it. But I'm just educating them on the fact that loads of people have these things and have no pain and may never have any pain. Don't worry, let's just focus on this first. And then normally that helps. But again, that's why it comes back down to education. I'd say some of the most valuable outcomes I get from patients is when we have a really successful session on education and reassurance. I think those are the most powerful. They're not the sexiest things in the world. No one goes on a course about how to build rapport and how to communicate. And I'd say those are probably our strongest skill sets. Anyone can learn to do an exercise. Anyone can read a sheet or go on an app or whatever. The ability to really communicate, listen, articulate your thoughts, and just treat someone with genuine respect and care is so powerful. There's those people who have hip dysplasia, FAI, ankle sprains, knee meniscus tears, they don't go to a clinician, they just carry on with it. So we're seeing a group of people that might not have any history of anxiety, stress, depression, whatever, but they are bothered about it. I'm lucky to not have those things, but I know when I've had an injury, I have got worried about it. I thought, oh, geez, am I going to be able to work? Am I going to be able to do this? So there is that underlying level of new anxiety that we have to respect and address. And a lot of that comes out to just education, reassurance. And that's really quite vital. And it's easier to do with rapport.
Definitely is. Yeah, it's a major part of what we do. And you mentioned there that education part, that's come through pretty strongly a few times. It's helping patients understand what's going on with their body, and that even if there is that morphology like you described, whether it's a cam, pinch, anteverted, retroverted hip, whatever it might be, that doesn't necessarily mean that they're going to need surgery, but you're going to help to work to settle it down, and you can help patients improve their thoughts and their attitude towards it as their pain improves as well. And that's all going to be a big part of the treatment.
Yeah, for sure. I agree. And I think as soon as they're on board, and it might take a little bit of time to get them on board, but as soon as they are and they understand that, I think you can have real good outcomes.
Definitely. All right, we've had a chat about gluteals now. We've talked a little bit about the hip. I want to chat to you about hip flexors in a minute too. But while we're talking about hip mobility and range of movement, internal and external rotation testing and range of movement testing around the hip. Obviously, it sounds like people come to you, they often think that you're the hip guy, you're going to be really interested in their hip range of movement. When do you test hip range of movement, and when do you find that's actually relevant to what's going on?
Yeah, I would test it for all. I'd say even though I might not necessarily give individual exercises specifically to a range of movement deficit, like the things we mentioned, I would assess hip range of movement for every patient that presents in whatever capacity. I think it's really quite valuable. I think there's ways to do it that are probably better than others, and we spend a bit of time when I'm doing this on my course just to explain to clinicians the reasons as to why I do it in certain ways, because I think patients can present with levels of irritability that kind of can tarnish the insight that you're getting. So I think that's really important. But I certainly would assess it. The reason for that is it helps you build that clinical picture. If you're having someone that presents, let's compare those two patients, right? So we had the active young adult, and we mentioned earlier the gluteal patient. So we had young, active, very fit, healthy adult, and then we had maybe more sedentary, less active gluteal tendinopathy patient decades apart. I'd still want to understand their hip ranges of movement. On one hand, I'm trying to understand, is there a hip morphology that would correlate with a potential hypothesis, like the things we discussed, dysplasia, FAI? And on the other hand, I'm trying to understand with the other patient, is there another underlying hypothesis differential, like, for example, an arthritic hip that might be coexisting with a glute tendinopathy, or actually, do they even have a glute tendinopathy? Is it an arthritic hip that's masquerading or presenting like that? Or are there two things coexisting? And I think that starts to give you a little bit more. So I look at all of it to help my what I call a hypothesis roar rumble, right? Because when you're talking to a patient, you think it could be about 10 things. I've got 10 differentials in the ring. I've got to try and barge out a few of them by doing my assessment. And that's what your assessment should be. The assessment is trying to understand what I don't think it is, to see what's left, because it's hard in clinic to diagnose stuff. If you're seeing someone for the first time, clinical tests are they're limited. We have loads of restrictions and limitations. So that's not to say that when the patient's there, you say to them, oh, I can't tell you what's going on because none of these clinical tests have a high specificity or likelihood ratio. You just say to them, I think it could be this or this, and that's in your head, then you've got to that point by nullifying as much as possible. And a lot of that comes when you mentioned about hip range of movement, that will support that rationale and thought process.
You brought up a good point there. So oftentimes patients come in, they might have a couple of conditions going on, or they might suspect that they've got their hip joint is involved when actually they've got GTPS or vice versa, or maybe they've got a combination of that. So tell us a little bit about some of the clues. So if clinicians are listening and they've got a patient coming in with hip pain, what are some of the clues that are going to help them to identify whether their patient has got GTPS or whether the hip joint's involved, and how they can go about differentiating that?
First and foremost, the subjective is key. Subjective is absolute paramount, because not only does the narrative and the story paint a bit of a picture, the patient has all the answers. You shouldn't be jumping to getting them on the bed and doing clinical tests to try and diagnose something. You should have a real strong suspicion as what's going on before you even start touching them. But with that patient in particular, it can be challenging. So, for example, if you've got those two hypotheses, OA, osteoarthritis of the hip, and GTPS, a glute tendinopathy, you could argue and say, well, for OA, we have real obvious textbook signs and symptoms, in the sense of you've got an age and a demographic that increases your suspicion. You've got the time frame, which is usually a bit slow and progressive, which increases your awareness of it. You got the standard, like difficulty putting shoes and socks on, difficulty washing legs at the bottom, difficulty walking, difficulty getting in and out of a car. You got like real, like normal, obvious OA signs and aggravating factors. And then with your GTPS patient, who has symptoms probably in a different place, lateral hip, but also that lateral hip might be so sensitized that they've got symptoms then going into the buttock or into the thigh. You think actually the OA hip could also present with the symptoms there. So then all of a sudden you think the locality of symptoms now is off. Now I can't use that to differentiate, because it could be both. And then the GTPS patient saying to you, actually, I can't put my shoes and socks on. I can't reach down or my shoes and socks on or cut my toenails, because they can't rotate the hip because it hurts. They've got a contractile or compressive intolerance of the tendon, which means they can't do it. So now you're thinking, can you not do it because the joint is stiff or restricted, or can you not do it because the tendon is so painful that it stops you doing it? And that's why passively looking at the range will help you with that. And you think, okay, fine. Can you lay on that side? No, it hurts. On the other side, no, that also hurts. And then you have to dive into that and think, are you unable to lie on that side in bed because of contractile or compressive intolerance of the tendon? Or is it just because the joint is painful? But it starts to paint a bit more of a picture, because it's unusual for the joint to be painful if you're laying on the good side. Because really, if your knees are together, the hip isn't going to be that provocative. You'd be like unlucky if the joint was that irritable. But this time the patient's telling you distinctly, I've got pain here on the side of my hip when I'm laying on the good side. And then when I'm laying on it, it's distinctly painful on that greater trochanter. So then you're starting to subjectively separate these two things out a little bit. And that's when the kind of thought process of trying to understand a bit more about the patient in regards to GTPS is fairly pertinent, because we've got some key factors and risk factors that we mentioned. I think that the menopausal status of a patient is fairly pertinent to understand. The fact that those hormonal changes may have a catabolic effect on tendon health is imperative to understand, but also highlights the need to have good rapport for patients as well, because it's a sensitive topic to discuss. I'd get a black eye if I just asked someone if they're menopausal 20 minutes into appointment when they've come in with hip pain. They're not going to understand it, but I would explain why I'm asking it, why I was being quite thorough with it. So those things are quite important, and that will start to lead your thought process. Now, it may well be that subjectively you're finding it hard to differentiate between the two. It may be that then clinically you also will struggle to differentiate between the two, because again, they could coexist. They commonly do coexist. So it's a challenge at that point. And what you do there is embrace the ambiguity. I think it takes a good clinician to understand that working in that gray area is really quite a skill, to explain to the patient that, again, because they don't care too much, they just want to get better. You say, look, there's a couple of things that could be going on. We're going to address it by considering all of those factors. Then you carry on. All right. And I think that's a real important lesson. I think sometimes physios are just so keen to, has to just be one thing. It has to be anything. It's not. Sometimes there's a bit of both. And that's really, really quite important.
So you picking up the clues from the history, like you would with all things. And then you're going into that objective, going, okay, well, maybe we have both things going on, or you're still a little bit unsure because they're getting pain when they're lying on their side, they're getting pain putting their shoes on, like you mentioned, bending over to put their socks and shoes on, or getting dressed. So, what are some of the tests that you then like to use to help to identify which of those might be involved, or if there is both?
When you've got someone who has hip joint pathology, specifically the OA, you're not necessarily going to have the degree of specificity that you would do when you're testing for the glute tendon. So if you're doing a cluster of tests for the glute tendon, things like single leg stance, palpation, fader resistance test, side lying hip abduction with resistance, they're all looking at the compressive and contractile tolerance levels. So whether you can stretch it and it hurts, whether you can contract it in its most stretched position and it hurts, or in a range resistance and if it hurts, you wouldn't necessarily elicit that level of distinct response in a local area when you were thinking if it was just the hip joint. So then you're starting clinically to be able to separate these two things out a little bit. But the difficulty is when you're doing a fader resistance test is my favorite one, because it's one of the rare tests that we have that has a high level of specificity, meaning that it's specific to this. You bring the hip into full flexion, adduction, external rotation fully. So you basically do like a glute stretch, like piriformis type stretch, right? Fully rotated the hip. And then you would get the patient to resist back into their starting position, which is obviously mainly going first into internal rotation, extension, and abduction. So when you're doing those tests and you're trying to refute OA, what are you thinking? Is your OA hip going to let you come into full flexion, adduction, and external rotation? Probably not, which means you're going to struggle. And then you're thinking, actually, there's a passive inability to do that from the hip itself. It's not an intolerance from the glute tendon. Do you see what I mean? So it might that start when it starts to paint you a little bit more of a picture specifically. The cluster of tests are great. The Grimaldi tests, I think, are really useful to consider. And then from the OA perspective, I think looking at quadrant restrictions and range are the only things that really are going to be able to give you a good indication if that loss of range is there as a result of an arthritic hip.
So you tend to use those tests from Alison Grimaldi, and it's good to dive into some of those because we've got people that might be familiar with them. Maybe they're not super familiar with the cluster of tests, but you mentioned there some really nice ones that you might not expect the patient to have pain if they just have hip OA. And so if they have GTPS but not hip OA, you might expect it with that pain on single leg standing.
There's like kind of standing on one leg for 30 seconds to see if they can tolerate that level of position. So you'd see if that was painful. That's quite a good sensitive test, which means that if it's pain-free, you can't 100% rule it out, but it's starting to paint a picture that you might be able to rule it out. Now, palpating the side of the greater trochanter, which often patients get told that it's bursitis, commonly it's not. I'd say bursitis is there a very minority of the time, certainly in isolation, very minority of the time. Let's say 9 times out of 10, it's the tendon. Pain around that area, and then bringing the fader resistance test, which is the one that I said is when you're bringing a hip to your chest across your body and rotating it like how you would do a glute stretch, puts the glute med, so the glute med, which is the most commonly impacted tendon muscle with this. When you're bringing the hip into full flexion, adduction, and external rotation, it becomes the most stretched position of it. And this is kind of an interesting thing for people to consider, especially when they're doing like clamshell exercises, which commonly get prescribed. When you do a clamshell, you're on your side, your hips are flexed, feet and knees are together, right? And then you bring your knees apart. So you're basically in hip flexion and you're going into hip external rotation. But when you're testing the fader test, the reason why it's so specific is because it's specific to that muscle and tendon, because that's the thing that we're dealing with. So if you're in a flexed glute stretch type position and you're having to resist internal rotation and that elicits the pain and it's a specific test, that just reinforces biomechanically what the glute med does in hip flexion. It does internal rotation. So if you're doing a clamshell, you're putting it under compressive load repeatedly, which is why often patients find it painful to do, because it looks like it should work the glutes, but it doesn't. If anything, it would irritate it. So that's, again, a demonstration of just flowing your assessment into your management choices from a rehab prescription. And those are kind of the first three. And the last one would be like a side lying hip abduction. So just laying on your side, bringing your leg up, seeing if you can do that. And often I would do that passively first and getting the patient to just withstand that leg hold in mid-range. No one can effectively resist when the leg is halfway up your rear. Like, you got to be able to just like hold it and then resist it at that point. But again, it just gives you a little bit more understanding in regards to those lateral structures and what they can withstand.
We've actually got a great question from Tom Goom that I want to just run past you, get your thoughts on. And Tom asked, what's your thoughts on return to running with hip dysplasia? Runners tend to get a lot of conflicting advice, so it'd be great to hear your take on this.
I think if we're talking about someone managing it conservatively, I'm the biggest optimist. I think until someone, or there is a real obvious reason why someone can't get back to the stuff that they love doing, I'm all for them doing it. Hip dysplasia is no different. Like I said, people who have hip dysplasia would have had that level of hip morphology throughout their life. It's not just happened. So we have to consider two facts. Is there such a deterioration in hip health that has caused them to have that level of pain that is inhibiting them getting back to their sport? And have they done enough rehab to get back to running? Okay. What we can't do is focus on someone having significant hip pain as a result of hip dysplasia, have low quality rehab, and then just try and get back to running themselves. Often what we would have to do is consider, let's try and gradually, progressively get them to that tolerance that they can withstand running. And if they can, then that's absolutely fine. People have characteristics and levels of hip dysplasia and have no problems. And that's really important to consider. Unfortunately, there's still that misconception that running is bad for joints. Impact is bad for joints. We're great at adapting and tolerating these things. This is no different scenario. But I guess if you've got an individual who has significant pain, is rehabbing quite well, but really struggling to get to the point of where they can tolerate running consistently without the risk of their symptoms flaring up again, I think that's when you just have to be a bit more pragmatic and say, look, if we're going to manage it conservatively, like, that's the only thing that we're struggling to get you back to. But that's not us telling them to stop. That's just their lack of ability to tolerate what you're doing. What I wouldn't want someone to say is, you have X, you can't do Y. I think like it takes a lot to be that descriptive and decisive with that. And you could argue, you could listen to this and say, yeah, but Mehmet, you just said about clamshells, don't do this if you've got this. And then literally complete contradiction. But again, if someone could do clamshells whilst they have GTPS, crack on. Once the GTPS is fixed, they can go back to doing clamshells, much like the same with this. If they have dysplasia, you manage it, they get back to running, then that's absolutely fine. I see it a lot with the hip replacements as well. Don't run. You can run, like, it's fine. Life's too short, man. Let's just get on with it. It's fine. Just manage it. Make sure that individual can tolerate it and help them get back to that point. But there's a lot of information out there. If you've got a hip replacement, don't do this, don't do that. You can. Physically, you can. There isn't evidence to tell us contrary, and there isn't evidence yet at all that shows that it will have a negative influence in the long term. Until there is, then I'm thinking life's too short. These people have been in pain. They're not having these treatments to live with more dysfunction or limitation.
Let's have a chat finally about hip flexors. They cop a lot of bad press. There's lots of stuff that they get blamed for, everything from back pain, knee pain, and everything else. Tell us, why do hip flexors cop such a bad rap?
For some reason, the hip flexors just get blamed for a lot, mainly just, I think, location of where the symptoms are. Then, on the other hand, they do become irritable with other conditions. If you have FAI, if you have hip dysplasia, yeah, you can get irritability of the iliopsoas tendon and other hip flexors, but that's not the main problem. That's a symptom. Same with patients who have femoral neck stress fractures or bone stress injuries, get blamed for hip flexors just because it's there. There's just the locality of symptoms and where anatomically this muscle group is. I'd say it's getting up there with the weak glutes. So someone walks in and they say, oh, I've got tight hip flexors, or my tight hip flexor hurts. I just feel it's probably the joint. Even if it is painful at your hip flexor, it's probably something else that's causing it. Or it's not the hip flexor. Or as my good mate James Noakes would say, it's never the hip flexor, but sometimes it might be in some unique scenario.
Everyone that thinks they've got tight hip flexors always blames the fact that, I sit a lot, so my hip flexors got really tight from all the sitting. What's your thoughts on that?
I think it comes back down to the fact that things will feel stiff if you don't move. So it could be the joint that's stiff, it could be the hip flexors. Yeah, sure, muscles will get tight if you don't move. No one complains about, I've been sitting too much, my Achilles feel really tight. My anterior ankle feels quite stiff when I've got up from walk. No one really says that stuff. Like, it's just normal. Things get stiff if you don't move. It doesn't have to be pathologized. It is just normal. What isn't going to happen is if you're sitting at your desk, that your hip flexors are going to shorten and become you get like some sort of contracture. I think people think like we're way more fragile than we are, but it's the perception. If you're stiff, you sit, you get up, it feels tight, you think it's shortened. But it probably hasn't. It probably hasn't. And we're certainly not going to get like contractures of the hip flexors just because people work office jobs.
When patients come in and they say, I've got tight hip flexors, or if you suspect that there's hip flexors involved in their pain, what sort of test do you tend to do?
If I think that they've got iliopsoas type groin pain, I would probably do two things, I think, and it falls again, because if we're dealing with a muscle or muscular tenderness or tendon dysfunction, I'd want to do similar to what we've said before. Some of the key things, especially with those who have hip instability, who have secondary iliopsoas pain, I quite like doing a plank and a 3-point plank at that as well. So the iliopsoas acts as an anterior femoral head stabilizer, especially in the first 15 degrees of hip flexion. So often people who have instability, and this is, and I need to caveat this heavily with, this is probably the only time that I would, this is more my opinion and approach. This isn't based on evidence, but often when you have someone who has an instability of the hip, they have an intolerance to do that 3-point plank. And certainly as you go from a plank into a pike, where you increase the hip flexion through a trunk or pelvic flexion or rotation, often they struggle or are intolerant to do that. So that just gives me a little bit of insight into resisted anterior load of those structures with hip flexion to see if they can tolerate it. And often they can't. So it just gives me a little bit of information there to then help with my rehab further down the line. Looking at range of movement, Thomas tests are great, but Thomas test has to be done really well for it to be effective. So this is one where you're sitting off the edge of the bed, hugging the knee, and the other leg is dropping down. That hugging of the knee that restricts and limits the pelvic position is what the test lives and dies by. Like, it has to be in that position for it to be effective. If it is, then it gives you a little bit of specificity into that flexibility of the anterior structures. But again, at that point, like, I'm not like overly stressed about trying to do some sort of like passive treatment to loosen it up. I would just maybe encompass that with some of the exercise that I choose. And also in that fully stretched position, I would often get them to resist as well. So I can get some insight into the contractile tolerance in a fully stretched position, in that Thomas test position also. You can probably gauge from the prone hip extension, but difficulty looking at that, it's not going to give you much to play with anyway for most people. So I'd want to look at those two things. And then I would just go a little bit further to assessing the contractile intolerance when they're on their back with short and long levers, mainly for me to just figure out like how irritable it is. So then when I'm picking exercises, I'm picking the ones that are pitched at the right point. Not so much to think from a diagnostically, we've got as much as we're going to get. If it's painful to contract it, fine. If it's painful to stretch it, like, we're getting some insight. That's not the diagnosis. That's just like part of a clinical pick. The main diagnosis is the joint. This is just like something else that's going on that we have to just still encompass within our rehab, but not put just all the focus on it.
You mentioned there a 3-point plank and moving into a pike position. Can you just clarify that a little bit about how you might get a patient do that?
Let's say you get someone in a plank, right? Normal plank position, on their elbows, on their toes, like good form, on 2 legs. And they say to you, yeah, I can do that. It's not too bad. Let's say their right hip is the painful one. And you say, okay, cool. Can you lift your right leg up? So you extend the right leg. So you basically are doing a plank, but just with the left leg. And they say, yeah, that's all right. The right one's a little bit stiff to hold up, but I can do it fine. And then you say, swap around. And then you get to swap around. And what often will happen is they just can't do it. They can't lift the left leg up because it's too painful, and they can't withstand that force and load going through the hip on that right-hand side. So they normally just can't do it. They can't lift the left leg up. So I'm thinking that's quite a big difference from left to right, first and foremost. Now, it doesn't just give that stability in neutral. It goes as you go through flexion. So what I would normally get them to do, let's say they could lift the left leg up. The right one is a bit painful, but they can do it. Then I would progress it to starting to lift their butt up into the air. So you keep your legs straight, and then you just start lifting your butt up, so into the pike position, but not too much. And then dropping it back down to neutral, and even just slightly past as well, to see if it causes pain. Like, if they can or can't tolerate it, it's just trying to paint a bit of a picture in regards to what's going on, especially in those like first degrees of flexion. And just being mindful that's in a long lever. So then when I get them on their back and I'm doing other tests for the hip flexors in short lever, like I said, I'm just trying to figure out where their level of irritability possibly would be.
Yeah. So you're getting them to lift one leg off the ground, so they've got 3 points of contact on the ground instead of 4. And then within that 3-point contact, you're then going into a pike position. So they might have one leg still off the ground, then moving towards a bit of a pike position, coming up a bit, and then coming back down into like neutral or maybe a bit past, you mentioned there.
Absolutely, yeah, just to see how it responds to it. But I would say often if it is irritable, like that first hold is normally a big problem. And unfortunately, like it's not a standardized clinical test. It's not. I've based this around like anatomically has a high prevalence, and iliopsoas tendinopathy and overactivity of those structures, especially for hip dysplasia, is quite commonly correlated, and there is a causal relationship between that as well. And equally, biomechanically, that's what these things do. So I've just tried to merge them together. And these are one of the things that often you can pick up. That's not to say if they can do it, there's no hip dysplasia. That's just, I'm just trying to, my main focus on that is if they can do it, then I know I can use that within their plan, because I know that's still helping with the stability. That means I can still use that as an exercise potentially.
So if they can't, you're maybe suspecting that there's some hip flexor involvement, but there may be some hip dysplasia in what's going on.
I would want to know if there is. I want to look into that, yeah, and I'd just be mindful of that. Or if not, I would just say, well, it's unusual to get that level of hip, so as irritability, just randomly as a primary diagnosis, unless you're like a sprinter, hurdler, long jump, whatever, like someone doing explosive, or a dancer where they're kicking their leg at the top of range repeatedly for like 3 hours on end. Like most people aren't doing that. So it's unusual for it to be a primary diagnosis. So that then does raise my index of suspicion. At that point, then I'm thinking, okay, we will use that as part of our rehab journey for that individual at whatever level that we think that they can tolerate it. And it might be that they can't do that at all. You might give them a dead bug. You might go from short to long lever and just use the weight of the leg to start to load it. So we're not doing it against resistance, we're just using gravity and the lengthening of the leg and the weight of the leg essentially to just gradually load it from that eccentric property of the muscle.
Nice. And I think that brings us up into where we'll wrap it up, which you mentioned there, some really nice starting exercises. For instance, if they can't cope with the long lever stuff, that dead bug might be a nice place to start to help to get some eccentric strength there. What are some of your other exercises you like to work through or progress through when it comes to hip flexors? Iliopsoas related groin pain.
Once that irritability has settled, so if we've progressed a little bit, some of my favorite things are using that kind of plank position. So sliders I use quite frequently. So like double or single leg sliders into full pikes. Or if people don't have that, they can use a Swiss ball, exercise ball. And if the pike is too difficult, doing things like knee tucks also are really useful to do, because they can like just do a shortened lever. For me, I find that really beneficial. As things are then continuing to increase and improve, I try with all my rehab to start doing 2 or 3 for ones. So 2 for 1 is like I'm doing 2 good movements in one exercise. So for example, you could do like a psoas march. So if you're laying on your back, right? Laying on your back, knees are flexed or hips are flexed to 90 degrees, and you've got a band around your feet, right? So psoas march would be like you push one leg all the way down, bring it back up, and then straighten all the way down the other leg and bring it back up. And basically, as you're moving one leg, the other one is so rigid that you're holding it against the resistance of the band. Now, my 2 for 1 with that would be to get them to do a hamstring bridge. So laying on your back, heels on a bench or a box, 90-90, lift them up. So purely isolated hamstring bridge, and then do the psoas march at the top of that. So you work in your hamstrings because they're statically having to hold you in that position. And then you're doing the hip flexor march with the band as well. So you're doing 2 for 1. That's tough, but just an example of where I would sometimes try and do, I guess, like multiple things at once. It's quite intense, quite hard work. Another example would be, if you've got someone completely supine on their back and you've been doing the leg raises, that's easy, right? So if you put a medicine ball between their legs or a Swiss ball, and you do an isometric adduction squeeze and then do the hip flexion raises with 2 legs, that's quite tough. You get them hanging from a bar and doing toe taps, toe raises. Just imagine someone hanging, swinging, and they've got the Swiss ball between their ankles and you're squashing the ball. and then you're doing straight leg raises. Then you've got abdominals, adductors, hip flexors. So the 3-for-1s, 2-for-1s. I'm being quite hard to this imaginary patient, but you get the point I'm trying to make.
Definitely working through from short lever to long lever, then incorporating like different muscle groups at the same time so you can actually get a little bit more bang for your buck or intensity. I think that's a really nice place to wrap it up. We've covered a lot of great topics. There's a lot of myths and misconceptions, and we've explored a lot of those, and how physios out there can share accurate information with their patients and take an evidence-based approach to assessing and treating the hip. So really appreciate you coming on and sharing all that with us today, Mehmet.
Yeah, thank you for having me on. It's been great, and I really enjoyed it. And hopefully people listening find it useful. And if you've got any questions, just feel free to reach out.
Where can people find you, Mehmet? What's the best place to get in contact with you or to see what you're doing and you got going on?
For patients, I would say my website, which is just thehipphysio.com. And then my main social media platforms are Instagram, YouTube, and X or Twitter. If you search for the Hip Physio, you'll find them. My main one is Instagram, and at the moment on YouTube, I'm starting to create a lot of patient-centric videos because I get a lot of referrals from physios, and what I wanted to have is like a place where patients can go and just learn a bit more about their problem, how to manage it, and just to cut out all the BS that they might find out online. Yeah, that's something that's developing and that's growing.
Perfect. So check you out on Instagram and Twitter or X, and YouTube as well, hey? We'll have links to all those in the show notes.
Thanks, buddy. Thanks a lot. Yeah, thanks for your time and great questions. Thanks for having me.
Thanks for coming on, Mehmet.